We are going to discuss a new topic on hematology. But the moment we speak about hematology, the first thing is the basics of hematology. In the basics of hematology, the most important thing we are going to discuss is the marrow first, because you have to know about the bone marrow and the related examination part, and all these things are very, very important for exams. When we think about the bone marrow, when we move on to the topic of the bone marrow, the most important thing you have to know is about the types of the bone marrow, the composition of the bone marrow, where there are a lot of questions being asked. The first one you have to know is the types of the bone marrow, which is going to be the two types, that is called the red marrow, and second one is the yellow marrow. So when we think about the red marrow, the most important aspect of the red marrow is that it is hematopoietic in nature, which means these are the ones that contain the hematopoietic cells. They are basically hematopoietic, and these are the ones that are going to give rise to your erythroid, lymphoid, myeloid, and all these things. And these are the hematopoietic tissues in the marrow. If you ask about the yellow marrow is basically non-hematopoietic. It doesn't have any hematopoietic function. It is non-hematopoietic in nature. That is because the yellow marrow is just made of a fatty tissue. It doesn't contain any precursors for the common cells that we see in the peripheral smear. It's just fatty tissue and doesn't have any hematopoietic function. If you ask me about where the location of all this red marrow and yellow marrow, the most important location of the red marrow is in the flat bones. The flat bones are the very important components of places where you have the red marrow and the hematopoietic function is kicking on. If you ask me about where the red marrows are, you can see in the skull, you can see in the pelvis, you can see in the sternum, you can see in the ribs, and you can see in the vertebra. All these things are basically considered to be the flat bones. That is why you see the red marrow predominantly in these areas which contain the flat bones, number one. And the second area where you can see red marrow to an extent is in the epiphysis and the metaphysis of the long bones. Epiphysis and the metaphysis of the long bones, where you can definitely see a lot of red marrow and the hematopoietic function going on. Where you see the yellow marrow, which is non-hematopoietic, typically it is seen in the diaphysis, that is the shaft of the long bones. Diaphysis or the shaft of the long bones. This is where you see the yellow marrow predominantly. This is the place. Okay, fine. So now you have known about the differences between the red marrow and the location of the red marrow as well as the yellow marrow. So once we know about the difference between the red marrow and the yellow marrow, we can see next thing is the marrow cellularity. So which is a very important thing to understand. Whenever you take the bone marrow, first thing you see is the marrow cellularity. The normal marrow cellularity is given by the formula something called 100 minus H. 100 minus H is something, it's very important formula. That is what we tell as to be the marrow cellularity. If you ask me about the normal cellularity of the marrow in a newborn by this formula, if you ask me, the newborn age is typically 0. If you ask me about the newborn's normal marrow cellularity is approximately 100%. 100% is going to be the marrow cellularity in the newborn. If you ask me about a child whose age is approximately 10 years of age, you can clearly tell the marrow cellularity is going to be approximately more than or equal to 90%, because by the formula if you apply it's going to be 90% or more. If you ask me the marrow cellularity in a standard adult individual, typically it is going to be somewhere around 30 to 70% depending on the age again. So this is what is the standard definition will be given in many of the textbooks, that is 30 to 70% is the normal marrow cellularity, where they would have given less than 30%, we call it as a hypocellular marrow, and more than 70% we are going to call it as a hypercellular marrow. So this is what we are going to tell in the first place. The moment you tell about the cellularity, the next thing to know is about what are the different types of cells that different types of lineage that contribute to the cellularity of the marrow. What are the different types of lineage? I can divide the lineages into number one in the erythroid lineage. I can tell first one is the erythroid lineage, and second one I can tell is the myeloid lineage cells, and third one I can tell the lymphoid lineage cells. Erythroid, if you ask me, erythromyeloid, lymphoid, if you ask me about the megakaryocyte lineage, it's very small in number. I can write separately. If you ask me about the megakaryocyte lineage, how much percentage it contributes to the megakaryocyte lineage. The megakaryocyte lineage typically contributes only up to 0.5 to 2% of the nucleated cells in the marrow. If you ask me about the erythroid typically contributes approximately 20 to 40% of the nucleated cells in the marrow. If you ask me about the myeloid lineage typically contributes approximately to 60 to 75% of the nucleated cells in the marrow, which means you can clearly see the myeloid is almost 3 times more than the erythroid. This is one of the things you have to know, because the peripheral smear, the RBCs clearly outnumber the WBCs, but whereas in the bone marrow, it is the myeloid lineage cells that are more compared to the erythroid lineage cells. Usually that's what they will ask you in exam. What is the myeloid erythroid ratio? You have to answer approximately 3:1 is the standard answer in the exam, because the approximate myeloid erythroid ratio is somewhere 2 to 4:1. That is what is the usual thing, but in exam you can take an average until that is 3:1 is the normal myeloid erythroid ratio, which means the myeloid is more in number compared to the erythroid series in the marrow. If you ask me about the normal lymphoid, what will be the approximate numbers? It contributes approximately 10 to 25% of the nucleated cells in the marrow. If you dissect and if you break down the myeloid series, I can break down into neutrophilic series. I can break down into next one eosinophilic series, and I can break down the third one into something called a basophilic and mast cell series, because mast cells are nothing but tissue basophils, but anyway you can break down into 3. If you ask me how much the neutrophils are contributing, if you ask me, neutrophil contributes approximately 50 to 65% of the nucleate cells in the marrow. Eosinophils contribute approximately 1.5 to 5%, and if you ask me about the basophils, it contribute to less than 0.2%, which means if you ask me the least amount of things that contribute to the peripheral smear as well as the marrow cellularity, it is the basophils, very less in number, so less than 0.2%. If you ask me about the lymphocyte, the next thing they will ask you is about the T to B lymphocyte ratio, T versus B lymphocyte ratio. If you ask me which is more compared to T or B, the clear cut answer must be T lymphocyte compared to the B lymphocyte, where the ratio is approximately 3 to 5:1. They clearly outnumber by 3 to 5:1 the T cells. And if you ask me the peripheral smear which is more, again the answer must be T cells, because T cells are the ones that are more in the peripheral smear as well as the bone marrow. The T cells are more in number, very simple. 3 to 5:1 is the ratio. Simply you can tell 3:1. You can remember myeloid erythroid ratio 3:1. T B cell ratio also you can remember as 3:1, which is a very important number. At the same time, if you ask me about the plasma cells, what are the things that contribute to the plasma cells? Approximately 0.4 to 3.9%, or you can tell 0.4 to 4%. This is what is the number that is contributed by the plasma cells in the bone marrow. So these are some of the important numbers that you have to know about the marrow cellularity. So the least is the basophilic and maximum is the myeloid series, especially the neutrophil series that is going to be. The neutrophil series means I don't only mean the mature neutrophils, I also mean about the neutrophil precursors like myelocyte, metamyelocyte, promyelocyte, and all these things will come under the neutrophilic series, not only the mature neutrophil. So these are the marrow cellularity. So what are the different other type of cells in the marrow? You are going to call something called the stromal cells. Stromal cells are not typically hematopoietic, number one. They are not hematopoietic in nature. So we can talk about the stromal cells. These are not hematopoietic, very important. These are not hematopoietic cells in the marrow. So if these are not hematopoietic cells in the marrow, so what are the basic functions of the stromal cells in the first place then? So what could be the basic functions of the stromal cells? So if you ask me about the basic function of stromal cells, you have to know the types of the stromal cells. If you ask me about the type of the stromal cells, number one, the first one, you have something called adventitious reticular cells. You have something called adventitious reticular cells. Then you have something called mesenchymal stem cells, which we can call MSC, mesenchymal stem cells, or mesenchymal reticular cells as well. Number three, you can tell the macrophages, which also form one of the important components of the stromal cells. So if you ask me about what are the functions of the adventitious reticular cells, these are the ones that accumulate to form the fatty tissue or the adipocytes. So these are nothing but the things that accumulate as fatty tissue. This is what we call as the adventitious reticular cells. Next, coming to the most important component, that is the mesenchymal stem cells. If you ask me about the mesenchymal stem cells, these are the ones which are going to form something called multipotent stem cells. These are multipotent in nature. Multipotent in the sense, do not confuse with the hematopoietic multipotent or pluripotent cells that gives it the hematopoietic nature. Clearly I told you these are non-hematopoietic cells. These are not hematopoietic cells, which means multipotent means they are going to give rise to multipotent lineages, that is mesenchymal origin, like adipocytes, not the hematopoietic cells. Adipocytes, or probably they can give rise to macrophages, they can give rise to fibroblasts, they can give rise to fibroblasts, they can give rise to osteoblasts, they can give rise to osteoclasts, they can give rise to chondrocytes, they can give rise to myocytes, that is the muscle cells, they can even give rise to endothelial cells. So all these things can be formed from this mesenchymal stem cells. This osteoclasts and osteoblasts are different. Osteoclasts belong to the reticuloendothelial system of the bone marrow. Bone. If you ask me the RES of the bone marrow, it is the bone marrow macrophages. If you ask the reticuloendothelial system, RES of the bone, that is the osteoclast. Similarly, you have RES in many places. For example, in the brain you have microglia, in the liver you have Kupffer cells, and in the spleen you have splenic macrophages, and in the lungs you have alveolar macrophages, and the placenta you have something called Aufbau cells. All these things we know already. But we are not talking about those things here. We are only talking about the mesenchymal stem cells, which are multipotent in origin, which can give rise to many mesenchymal lineage cells in the bone and the bone marrow. So that is what is contributed by the mesenchymal stem cells. Apart from that, they also form a lot of supportive function. Supportive function, they don't only form the physical support, they also form the growth factor support, which means this is the most important thing, because almost every single growth factor that is needed, for example, if you ask me about the GCSF, GM-CSF, every single growth factor is going to be synthesized by the mesenchymal stem cells, with the exception being two important growth factors. One is the erythropoietin and second one is the thrombopoietin. If you ask me where the erythropoietin comes from, typically you know very well they are going to originate from the kidney. Straightforward and easy point. It is from the kidney. That's it. If you ask me where the TPO comes from, typically it comes from the liver predominantly. This is where the TPO comes from. Erythropoietin typically comes from the kidney, TPO typically comes from the liver. If you ask me, the breakdown, 90% of erythropoietin is from the kidney and 10% from the liver, but still erythropoietin means kidney, TPO, thrombopoietin means liver. If you ask me where in the kidney, we will discuss later on, it is from the peritubular interstitial fibroblast-like cells. This is where the erythropoietin typically comes from, near the proximal convoluted tubule predominantly. But anyway, we will discuss more in detail about the erythropoietin later. These are two things that doesn't come from the your mesenchymal cells. Apart from that, everything usually comes from this stromal cells only. And macrophages, if you ask me where you typically see the macrophages are usually located around the sinusoids. In the bone marrow, you have sinusoids. Typically, the macrophages are seen around the sinusoids. Like how you see this Kupffer cells are all around the sinusoids. Similarly, you are going in the space of this. Similarly, you are going to see the macrophages in the bone marrow around the sinusoids. So this is what you are going to see in the extravascular surface of the marrow, not in the intravascular component. The extravascular around the sinusoids. So next, after knowing about this marrow cellularity, all these points, we are going to know about the bone marrow examination. Bone marrow examination, which is a very crucial thing to understand. Bone marrow examination has two components. One is called the bone marrow aspiration and second one is called the bone marrow biopsy. If you ask me about the aspiration versus biopsy, typically we don't perform biopsy in almost all the cases. We perform only bone marrow aspiration in most of the cases, which itself is a clue to diagnosis, as well as for many necessary clinical reasons we only do the aspiration. Biopsy is usually typical example where you need a biopsy in the dry tab, where it cannot aspirate the bone marrow and you don't get anything when you aspirate. In those conditions you can do a biopsy, but which we'll discuss later on in the same subsequent topic. But anyways, these are two things you have to know. One is the bone marrow aspiration, second is the bone marrow biopsy. Most of the times bone marrow aspiration itself is more than enough. And what are the indications for bone marrow examination? That is the question. Indication can be either diagnostic or it can be prognostic. If it's a diagnostic indication, there are lots of diagnostic indications are there. From the time you diagnose any unexplained anemia, if you don't know what is the cause of anemia, you can use bone marrow examination, or you can tell for unexplained any cytopenia, including megakaryocyte, including thrombocytopenia, any other cytopenia. Or if you think about a disease that is an aplastic anemia, or if the patient is having a thrombocytopenia, pancytopenia. In those conditions, you can do a bone marrow examination. Or if you are suspecting a myelodysplastic syndrome, or if you are suspecting a leukemic picture, leukemias, if you are suspecting a leukemias, or if you are suspecting a myeloproliferative disorders. Like many things will come under myeloproliferative disorders, like you can have your CML, or like you have essential thrombocythemia, you have polycythemia vera, primary myelofibrosis. In all these conditions, your bone marrow examination is of vital importance. Myeloproliferative disorders, or you can even have something called a granulomatous disease. When you are wanted to diagnose something called a granulomatous disease like TB or sarcoidosis, I've seen a lot of patients where your lung disease will not be there, abdominal disease will not be there, just the patient will come with a PEO, pyrics of unknown origin. We take the bone marrow and examine, we find out something, for example, a TB, which is a granulomatous disease. We have found out a lot of cases of PEO by bone marrow examination as a tuberculosis, where the mantle will be negative and even there is no lung, brain or any other organ related lesion. Still bone marrow gives a clue. So that is why it's very important. Why TB loves bone marrow? Because again, macrophages are there in the bone marrow. TB loves macrophages. That's why the first site of infection in the lung is the alveolar macrophages. First site of infection anywhere else is the macrophages, because they have evolved to live within the macrophages. That is the reason why they love the marrow as well. So granulomatous disease. Not only this, even including sarcoidosis, including many other things, you can use the bone marrow examination for many granulomatous diseases. For that being, as I explained to you in a PEO, pyrics of unknown origin, as a last resort, if you don't get any diagnosis, you can do a bone marrow examination indicated. Then you can see when you are thinking about a multiple myeloma and other plasma cell dyscrasias, you can do a bone marrow, because majority of the plasma cell dyscrasias, the definition of this plasma cell dyscrasia is based on the number of plasma cells in the bone marrow and the blasts in the bone marrow. So definitely in these conditions you can use. So you can use sometimes in storage disorders also, for diagnosis of storage disorders also, like Gaucher's disease typically, where you see the macrophage in the bone marrow will have a crumbled paper appearance. You know that very well. These are very classical facts. Storage disorders. Then you can do in amyloidosis very rarely, especially in primary amyloidosis, which means it's a light chain amyloidosis. You can in those conditions you can do a bone marrow examination. Apart from this, there are a lot of other examples. Lymphomas, typically Hodgkin lymphoma, non-Hodgkin lymphoma, especially if you suspect a marrow infiltration. Especially if you are suspecting a marrow infiltration. I told only certain examples of the bone marrow, but in general you have so many reasons why you can do a bone marrow. So it's not that you have to do only in these conditions. If you ask me about the prognostic reasons why you are going to do a marrow, for prognostic reasons means typically after chemotherapy, post chemotherapy, especially in a leukemia patient, characteristic example, you can see the cellularity once again. And you can confirm whether the chemotherapy is working or not. In those conditions, definitely for prognostic and follow-up reasons, you can do a bone marrow once again. Or second thing where you can use is in after treatment of an isolated cytopenia. After treatment of an isolated cytopenia, this is not that powerful indication, but still you can do a bone marrow to confirm the progression of the lineages, that whether they are proliferating or not after the treatment. Before treatment, they won't proliferate, that's why you have a cytopenia. After lineage, whether the proliferation of that particular lineage is happening or not, again you can confirm with the bone marrow examination. Or in a bone marrow transplanted patient, especially in a bone marrow transplant for follow-up cases, for follow-up whether the stem cells has been accepted and they are proliferating, whether the bone marrow has become functional after the transplant or not. Again you have to, because before the transplant they are going to completely ablate the marrow, and after the transplant you have to be sure that the bone marrow becomes cellular and starts their function. So all these things are extremely important in understanding. So these are the indications for bone marrow. If somebody asks you about the contraindications for bone marrow, what will you tell? So if somebody asks you about the contraindications of the bone marrow, there is no absolute contraindication for a bone marrow. That's what I tell. There are a lot of relative contraindications, but if you ask me, there is no single absolute contraindication for a bone marrow examination. Even very severe thrombocytopenia, this is what asked in recent AIIMS exam, even a very, very severe thrombocytopenia is not a contraindication for doing a bone marrow examination, because it becomes a relatively an indication to a bone marrow examination if you have an unexplained thrombocytopenia. So that is why even severe thrombocytopenia is not a contraindication for doing a bone marrow. Probably one absolute contraindication, if you ask me, probably if there is an infection going on at the site of bone marrow examination, then you might not do in that area, but still you can do in a different area. So again, it's not an absolute contraindication overall, it's only a contraindication in that area, in that particular site, if there is an infection going on in that site. But apart from that, it's not a contraindication at all overall. If you ask me, you can do in a different site, not a problem at all. So these are some of the indications and contraindications of the bone marrow. So now if you move on to the next section, that is if you see this what I'm going to discuss, you know very well. I'm going to discuss about the sites of bone marrow examination. What are the sites where you can do a bone marrow examination? The most important and the classical and the commonest site where you are going to do a bone marrow examination is in the posterior iliac crest. That's why you're going to. This is the most common as well as the preferred site for doing a bone marrow examination, as I have mentioned. If you ask me the other sites where you can do bone marrow examination, the anterior iliac crest also near, just 2.5 to 5 centimeter posterior to anterior superior iliac spine. You can prefer doing a bone marrow aspiration or biopsy, but to be honest, this is preferred only if the posterior iliac crest is not palpable, or if it's not able to, the landmarks are not able to be localized clearly. In those, especially in severely obese patients, you can do, where ASIS, anterior superior iliac spine, is very easily palpable even in obese patients. So that is the reason why in those patients, selectively you can prefer a anterior superior iliac, this anterior iliac crest. Sternum is another preferred site. Typically we prefer in the manubrium sterni. As I mentioned, manubrium sterni, typically at the second or third intercostal space area, near the second or third intercostal space area. In those conditions, you can prefer a sternal region also, but be very sure it should be done only in patients who are aged more than 12 years of age. Don't do in younger children because of the risk of perforation of the sternum, because bones will be soft, and because of that you might go beyond the bone and you might injure the vital structure which is present behind the sternum. So avoid in less than 12 years of age. And if you see other sites, if you ask me what are the other sites you can use for bone marrow examination, you can prefer tibia, especially in the anteromedial region of the tibia, that is typically the shin of the tibia on the top portion. Usually this is done only in children less than 12 to 18 months of age. Only children less than 12 to 18 months of age. You don't generally prefer this in older children. Number 2, where you can prefer is even in the vertebral body. Textbooks mention, but I have not seen anyone doing from the vertebral body. But really, to be honest, this is also a flat bone and very highly, he is going to have a lot of red marrow. You can see the hematopoietic function in the vertebral body also, theoretically, but practically speaking, I don't think anyone does here. But theoretically, yes, many books do give. If you ask me what are these two images, tell to obtain from the posterior iliac crest only, but what are the typical positions for obtaining a marrow from posterior iliac crest? First one, this is in the prone position. Yes, you can do in a prone position, to be honest, yes. Then second one, you can do in a lateral decubitus posture also. You can do this in a lateral decubitus posture as well. So these are the places, these are the positions. Even certain textbooks do give you can do a bone marrow by sitting position also from the back. But generally I don't think, again, only in the theory they have given, but I don't think anyone does in these purposes. Prone is something what is preferred. At the same time, the lateral decubitus posture is also something what is preferred. But apart from that, I don't think sitting is generally preferred. But you can avoid sitting, but even some textbooks do give about the sitting posture as well, especially in children, if you want from the posterior iliac crest. So these are some of the sites where you are going to do a bone marrow examination. Apart from that, knowing the sites of the bone marrow examination, you can move on to the needles. What are the different needles you see in the that are helpful in doing the bone marrow examination? If you ask me about the needles, you have certain aspiration needles, you have certain biopsy needles also. If you ask me about the aspiration biopsy, even though I am going to tell about the names of these needles, nowadays it's not important knowing the names of the needles and all. Why it is not important to know about the names of the needles and all is because we are currently using only disposable needles. Many companies produce disposable and use and throw type of needles, which is not at all important. That's why it is not at all important to know about the names of the needles in the first place. If you want to know about what are the needles that are used in aspiration, the first one, the classic needle that used in aspiration is the Salas aspiration needle, one of the traditional needles. Then you have something called Klimas needle. Then you have Islam needles. Then you have something called biopsy needles. The classic biopsy needle is something called a Jamshidi needle. And you have something called Osgood needles. And you have something called, again, Islam needles. In this, if you ask me, even though Islam needles are written in both aspiration as well as biopsy, there are two different types of needles that are there in Islam needles, which are, one is used for aspiration and second is used for biopsy, but two different types of needles are there. But this Jamshidi is only a single type of needle which you can use for both aspiration as well as biopsy, because the arrangement of Jamshidi is like that. Aspiration as well as biopsy, you can use the same needle, you can use for both aspiration as well as biopsy in Jamshidi, but Islam you can use, the name only is the same, but the type of needles are something different in Islam. At the same time, if you ask me about the biopsy, what is the type of biopsy we obtain? We tend to obtain something called a trephine biopsy. Trephine is a twisting thing, isn't it? So it's a process. It's not something as with the needle, because many students do think that trephine is a needle, but it's not. Trephine is the procedure in what we do. A trephine biopsy means the procedure is the trephine procedure that we do. It's not the needle. So Jamshidi is what you have to remember. At the same time, Sala is what you want to remember. Sala for aspiration, Jamshidi for biopsy. But if they ask you, it can be same needle, Jamshidi can be used for both aspiration as well as biopsy. But all these things remembering is not that important, because we are going to use only a disposable needle in the current era. So if you ask me, this is the typical aspiration needle and this is the typical biopsy needle. This is a typical biopsy needle. What is the important significance of the aspiration and the biopsy needle? You can see how to differentiate in exam. You can see as a whole. This is the inner part you put in the this thing, isn't it? So that is the inner part of the aspiration needle. This is the real needle actually. This is the place where you're going to get the aspiration. But if you ask me as the overall, after plugging the internal needle into the external one, if you see, the needle length is going to be very short. And if you ask me, the needle is also going to be relatively thin compared to the biopsy needle. This is how in exam you're going to be seeing the aspiration needle, which means the needle part is very less and the body will be little bit bigger in case of, lengthier in case of a aspiration needle. But if you take about the biopsy needle, in the biopsy needle, the body will be very little, but the needle part is going to be very big in a biopsy needle. Needle part is going to have more lengthier compared, and at the same time it's relatively thicker. See, these are, I'm talking about the currently used disposable needles, but other needles like Jamshidi, Sala and all, it's completely different. They are steel body and completely it will be of a steel make thing. It's going to be used again and again by sterilizing it in the, like in your laboratory. But we are not talking about that because they are less preferred now, because they are something to be reused again and again. So we don't prefer anything to be reused in the current era. We use disposable needles. If you want to know about disposable needles, disposable bone marrow aspiration needles, it's supposed to be thin, little bit lengthier body, but very small needle part. At the same time, if you ask me about biopsy needles are going to be little bit lengthier needle, short body, at the same time internal one. If you ask me, there is something called a retriever. This is very important, because when you do a bone marrow, initially we thread inside and take the retriever outside, and again we thread only the bone marrow biopsy getting needle inside the bone marrow, because if you thread inside, that bone marrow goes inside the needle. Once after taking the needle out, you can use the retriever you can push the retriever inside, which pushes the marrow part outside where you can see clearly. So that is how it works. So that is why the retriever is very important in a bone marrow biopsy needle. So if you ask me about this, they are going to be relatively thick and they are going to be relatively more lengthier in nature. So this is what the difference between a bone marrow aspiration and a biopsy needle. And you can see this is the procedure of the bone marrow aspiration. And you can see once you put it in a plate like this or put it in a container like this, you can see a lot of aspiration particles here. You can see that very clearly. You can see a lot of particles over here. So these are the particles that are going to be seen. These are the bone spicules. Nothing else. These are nothing but the bone spicules. That's it. So these are the different types of bone marrow aspiration needles that you are seeing. Apart from that, if you ask me about the next important thing about the bone marrow examination part, it is about the complications. So is there any really complications of a bone marrow examination? To be honest, there are not much complications. In general, the complications are very rare. If they ask you the most common complication, it is just a bleeding, or maybe a little bit of prolonged bleeding. That's all. But apart from that, there are no real time life-threatening complications that are going to happen. This bleeding can be sometimes severe. It can give rise to retrobretal hematoma. How do you diagnose retrobretal hematoma in real life or in exams? You can just, when after a procedure like a bone marrow, the patient will be complaining of severe back pain. At the same time, the patient's hemoglobin will drop, patient's BP will drop, patient's hematocrit will drop. And if you take a CT and see, there will be a large blood collection or a mass that is seen in the retrobretal region. Typical example with the history of a bone marrow aspiration, you are going to diagnose a retrobretal hematoma. That's it. Next thing, you can see something called injury to the nearby structures. So that is also possible. For example, nerve, vessel injury, but very rare, because we select the regions. The regions we select for aspiration biopsy is not something very complicated. So it's very easy to do, except for the sternum. Apart from that, other areas are very safe. So injury to nearby structures is again generally very, very rare. Infection risk again is very rare because of the sterile precautions we use right now. So infection risk again is going to be very rare. And then tell you one more thing. For example, I told you many sites for bone marrow aspiration as well as biopsy. All the sites can be used for aspiration as well as biopsy except sternum. Sternum is the only site which I am not going to use for biopsy. Only aspiration in a sternum. Only aspiration. But every other single site can be used for both aspiration as well as a biopsy. And next, if you ask me about the growth factors, before concluding about the bone marrow, if you ask me about the growth factors, there are a lot of growth factors that are important which we discuss in subsequent sections. You have GCSF, GM-CSF, erythropoietin, thrombopoietin, interleukin 3, then you have stem cell factor. So many growth factors are there which are very, very important for processing the bone marrow. But we are not going to discuss in much in detail about all these things. But what we are going to discuss is, in the next subsequent sections, we'll discuss about how a stem cell will work and what is the RBC basis and all those things. The next section is going to discuss. At the same time, only last final thing that is remaining in the bone marrow section is the erythropoiesis and where the erythropoiesis starts and how it progresses in the adult life. Taking from the embryological period to the neonatal period to even in the adult life. If you ask me where the erythropoiesis first starts, typically the erythropoiesis first starts in the yolk sac. You can see very clearly the yolk sac is the first region where the erythropoiesis starts. They ask you when it starts, usually by day 16 or third week. Your erythropoiesis starts in general. Then if you ask me about the next where it starts, next place where the erythropoiesis kicks on is the liver and the spleen. Typically in the liver and the spleen, it is somewhere 2 to 7 months the liver and spleen will be active. From the second month to the seventh month, the liver and spleen will be active, 2 to 7 months. Then the bone marrow will start. Overlap from the bone marrow will start. Next, the overlap from the bone marrow will start. Usually the bone marrow starts around 5 months and continues from there on. So bone marrow starts taking over around 5 months. It starts increasing and takes over from 5 months. And after that, once the 7 months is stopped, after the 7th month, the bone marrow is going to be the only source of the hematopoietic function. Your liver and spleen, the hematopoietic function, the yolk sac obviously will regress within a couple of months, and the liver and spleen also will regress by around 9 months of age, which means at birth, your hematopoietic function, from birth onwards, your hematopoietic function will be carried out only by the bone marrow. But at birth, if you ask me about the bones that contribute, at birth, only bone marrow and literally all the bones, literally every single bone in the body will contribute to the bone hematopoietic function. That's why the marrow cellularity is going to be 100% at birth, which we discussed already. But as the patient moves on to the adult life, only the flat bones will take over. Even though I told you there are some areas like metaphyses and epiphyses of the long bones also still have some hematopoietic function, but typically the hematopoietic function will be taken over by the flat bones part. So that is, especially I have given here the vertebra, sternum and the rib. The vertebra is the one that is contributing to the maximal hematopoiesis in the adult life according to this graph. You can see very clearly. And tibia, femur, long bones, initially the long bones will be there. You can see in the postnatal period, but later on it again decreases over time, regresses with age. It's only the flat bones that take over in the adult life. So these are the different sites of hematopoiesis. In this, the most important points are, where is the first? That's the yolk sac. What is the time the yolk sac starts with? Initial, then what is that? Liver and the spleen. Then you have to go to the birth, all the bones in the bone marrow at birth especially. Then after you, as the person progresses with age, the long bones will regress and only the flat bones will take over. These are the different hematopoietic areas. So with this, we can conclude this particular part of the hematology lecture. With the next thing, we are going to discuss in detail about the stem cell and the RBC basics.